Let's look at hyperthyroidism. Hyperthyroidism refers to a state of increased basal metabolic rate resulting from elevated levels of circulating thyroid hormone. The thyroid gland is a fleshy, brown, bow-tie-shaped gland that is located in the neck. It lies on the thyroid cartilage and is attached to it. It's made up of two lobes, and these two lobes are joined by something called the isthmus. It may have a pyramidal lobe sitting on it, as we can see here. The thyroid gland produces T3, which is also known as triiodothyronine, or T4, also known as thyroxine. And this involves a process that requires iodine. There's a feedback system that is established between the thyroid, the pituitary, and the hypothalamus. Thyrotropin-releasing hormone from the hypothalamus acts on the pituitary gland, and this causes the release of thyroid-stimulating hormone, also known as TSH. TSH acts on the thyroid gland and causes the thyroid gland to release the thyroid hormones. The thyroid hormones also act via a negative feedback system on the pituitary as well as the hypothalamus to inhibit the production of TSH and TRH respectively. So it's like a seesaw effect. When thyroid hormone levels are low, TRH and TSH production increases. However, when thyroid hormone levels increase, it causes the TRH and TSH production to reduce. What are the causes of hyperthyroidism? First off, we have Graves' disease. Graves' disease is the commonest cause of hyperthyroidism. It is an autoimmune disease, and as such, it is more common in women. In this disease, the body produces antibodies to the thyroid peroxidase or thyroglobulin or TSH receptors, ultimately making the thyroid gland produce more hormones. Next, we have toxic multinodular goiter. We also have toxic autonomous adenoma, also known as Plummer's disease. These two causes are common in iodine deficient areas and are more predominantly seen in elderly people. In these conditions, the thyroid nodules become autonomous, meaning that they function on their own, independent of the signals from the higher ups, that is, the hypothalamus and the pituitary gland. Another common cause is Dread-Bezos disease, which is called iodine-induced hyperthyroidism. Other less common causes include Dequevance thyroiditis, which is a viral cause of acute thyroiditis, drugs such as amiodarone or lithium, exogenous thyrotoxicosis, which is a common situation seen in thyroid cancer patients who have been given excessive doses of thyroxine to suppress tumor growth. Another less common cause is neonatal thyrotoxicosis. This occurs in children who are born to mothers with Graves' disease. The mother's circulating thyroid antibodies cross the placenta into the child, and this is what causes that initial transient thyrotoxicosis in the child. The thyroid hormone acts on a bunch of stuff in the body, ranging from heart rate to gastrointestinal motility to protein metabolism. So the effect of excessive levels of circulating thyroid hormone would be felt all through the body. Patients may complain of weight loss due to the rapid catabolism, but would still have normal or sometimes increased appetites. They could also complain of eye protrusion, hyperhidrosis, which is also known as excessive sweating, neck swelling if there's a goiter, pruritus, palpitations, hyperdefecation. Hyperdefecation is differentiated from diarrhea in that the stool volume per day in hyperdefecation is normal compared to diarrhea where there's an increase in the stool volume primarily because there's excessive water being lost. On examination, the patient may seem agitated, restless. There's also lead lag and exophthalmos. Patient has a smooth velvety skin. There's tachycardia, most commonly due to atrial fibrillation. They have a tremor, sweaty palms, and they also present with palmar erythema. Patients with Graves' disease present with ophthalmopathy, which is the most common Graves sign, dermatopathy, and acropathy, which are less common. The main signs of Graves' ophthalmopathy are proptosis, periorbital edema, and diplopia. Dermatopathy refers to the thickened pigmented skin seen primarily on the pretibial area. Patients with acropathy present with finger clubbing and swollen fingers. Investigations to be done in a patient who is suspected to have hyperthyroidism include TSH, free T3 and T4 levels. This is the first and most important investigation to be done. Earlier, I explained the relationship between the thyroid gland and the pituitary gland. In hyperthyroidism, you expect to find elevated T3 and T4 levels and low TSH levels because of a negative feedback. However, in cases of secondary hyperthyroidism where the pituitary gland is what is stimulating the thyroid gland to produce this excessive hormone, you will also find elevated levels of TSH. Next investigation you'd like to do are TSH receptor antibodies, antibodies to tyrosine peroxidase or thyroglobulin, and this would commonly be seen in patients with Graves' disease. A thyroid uptake scan can be done in cases of goiter. Because Graves' disease is an autoimmune disease and it has been established that there's a relationship between Graves' disease and other autoimmune disorders, it may be useful to investigate for these as well. So think of diabetes mellitus, pernicious anemia, myasthenia gravis, vitiligo. Three management options exist. They are drugs, radioactive iodine, and surgery. The first choice of treatment usually varies by country or region. So let's look at drugs. Antithyroid drugs block the production of thyroid hormone, and examples of these are carbimazole, methimazole, and propylthiouracil. Propylthiouracil has the added advantage of blocking the peripheral conversion of T4 to T3. Because carbimazole and methimazole are also immunosuppressive, it is important to monitor patients while they are on these drugs. Beta blockers are also given because most of the actions of the thyroid hormone are enacted via the sympathetic nervous system. Next up is radioactive iodine. This is the first choice of treatment in some countries. It acts by destroying the thyroid gland. As you would expect, it is contraindicated in pregnant and nursing mothers. Lastly, we have thyroidectomy, and this can be total or subtotal, meaning it's either there's a complete removal of the thyroid gland or only a partial removal of the thyroid gland. And this is done in patients with massive goiters or patients who do not comply with drug therapy. It is very important to remember that a patient must be rendered euthyroid before initiating radioactive treatment or surgery. By euthyroid, we mean normal thyroid function, normal TSH, normal T3, normal T4. And if this is not done, it may precipitate a thyroid storm, which we will talk about in a different video. Also, it is important to monitor the levels of thyroid hormones and TSH during and after treatment to ensure that the patient is not tipped into a hypothyroid state. Thank you for watching this video. If you enjoyed this video, feel free to like and subscribe to my channel.